Test, test, 1, 2, 3. All right, Steve, we are ready to go live. So you're going to be live in 3, 2, 1. You are live.
Yes, Counselor.
You have a quorum and there are no citizens.
Thank you very much. Well, welcome everybody to the Finance Committee. We'll come to order. We have no citizens wishing to address the committee this morning, so we'll move on to item number 3, which is approval of the minutes from the June 25th meeting. And I'll entertain a motion for approval of those minutes.
This is
Charlie. Or second.
I heard Dorothy give a motion and Charlie give a second. Any questions or changes on the minutes? All those in favor of the motion, please say aye.
Aye.
Opposed? Motion is approved. We'll move on to the CFO report. Item 4, Ms. Clark.
Hi. Hope all of you are doing well this morning. There was some discussion last Finance Committee that I have invited Chris Clark, who is the partner at BKD that oversees our financial external audit. 2 items that I think deserve a little further discussion was the treatment on our interim financials for the COVID relief funds, specifically that $8.2 million that we received back in April, as well as a little bit of further reasoning behind the necessity. Sorry, I'm getting a lot of feedback. The necessity of that, a claim forgiveness of debt resolution that was presented for the first time last month. So I'm going to go ahead and turn it over to Chris, who should be on the call, and just let him give you some background on both of those subjects, if that's okay.
Sure. Thanks, Sharon. I appreciate the opportunity to visit with you this morning, and I've got some information that 2 issues that may answer some questions that existed in terms of how these transactions are being accounted for. And so I'll start with the CARES Act, and certainly this has been a subject of a lot of conversation in our industry because of uncertainty surrounding how these funds should be accounted for. The funding, the relief funds are coming in from a lot of different directions. They're being allocated in a lot of different methodologies, and so a lot of confusion exists. And a lot of hospital providers have been reaching out not only to accounting firms, but also the boards that set accounting standards to address how these funds should be accounted for. Specifically, the Governmental Accounting Standards Board has received a lot of questions from governmental hospitals like yours as to how the CARES Act funding should be accounted for. And they've actually, in the last week of June, issued what they refer to as a technical bulletin, which specifically answers questions that hospitals had related to how to account for these funds. And so, as you'll recall, as a governmental entity, JPS is required to follow the standards set by the Governmental Accounting Standards Board, which differs from standards set by the Financial Accounting Standards Board, which is the accounting framework that for-profit and nonprofit entities follow, but governmental entities follow the Governmental Accounting Standards Board. And to a large degree, those standards are consistent with each other, but there are also certainly areas where they differ. And this may be one ultimately where there's some differences between how you might account for these funds and a for-profit or non-governmental entity might account for these funds. So as it relates specifically to the provider relief funds, which represents the bulk of the funding that you've received, the Governmental Accounting Standards Board has indicated that those funds should be recognized when all eligibility requirements are met. And in general terms, there's 2 eligibility requirements that exist that dictate how those funds should be used. And they should be used to cover lost revenues that can be attributable to COVID-19, and they can be used to cover expenses that are specific to addressing the COVID-19 pandemic. And as an organization, once you've been able to document and show that you have met those eligibility requirements, that would be the point in time when you recognize that revenue. And as it relates to measuring those things, the federal government has actually weighed in on how you might measure lost revenues. And two examples that they provided was comparing budget to actual revenue, or comparing prior year actual to current year actual revenues, and using the delta between those two as a starting point as to what your lost revenues are due specifically to COVID-19. And so what our recommendation is, and I think that this is consistent with the rules surrounding the funding, and it's also consistent with the guidance that GASB has put forward, is that you would recognize those funds as revenue when you have experienced that lost revenue or incurred those expenses. And so let's say as of today, you've received $50 million of relief funds. If up until this point, you can demonstrate that you've lost $50 million of revenue as a result of COVID-19, or when you add that lost revenue to the COVID-19 specific expenses, and that number is greater than $50 million, then you would have recognized all of the $50 million as revenue. If you have received $50 million and you go through that measurement exercise and you can only demonstrate that you've lost $25 million of revenue and $5 million, and you've had $5 million of COVID-specific expenses, then you would have recognized $30 million of revenue, and $20 million would be sitting on your balance sheet as a liability. In most cases, for the hospitals that we work with in Texas, the funding that has been received to date is far less than the lost revenues that they've experienced as a result of COVID-19. And so most organizations, by the end of their fiscal year 20, will have recognized all of the CARES Act funds as revenue in the financial statements. Early on, there was some uncertainty as to where that revenue should be reflected in the income statement. Many of your for-profit or non-governmental peers are recognizing that revenue as operating revenue. But this GASB technical bulletin that I mentioned earlier specifically addresses that question as well. And GASB views these funds or this transaction as a non-exchange transaction where you're receiving funds from the government, but you're not directly providing the government any reciprocal value. And so non-exchange transactions are recognized as non-operating revenue. So this technical bulletin did give us some final guidance that this revenue should be reflected in the income statement as non-operating revenue. So that's a summary of the accounting associated with the provider relief funds. Are there specific questions that I can address for you?
Thank you, Chris. Appreciate it. Any questions for Chris on this? This is a technical question I believe DT raised in our prior meeting, which is the reason why we asked Chris to come today. Any questions for Chris on this account we had this morning?
Chris, appreciate the explanations. Could you be more specific to us from what you know about our data? Are we going to be able to recognize all of it, or we still? I understand the general concept. I just want to make sure as we book them, do we have any liability that we need to book on the balance sheet statement?
Sure. I think that measurement is ongoing because. You have received different tranches of payments from the relief fund, and I believe that the measurement is ongoing right now in terms of measuring that lost revenue and making sure you're also factoring in the COVID-specific expenses. Sharon might be able to speak to this better. My hunch is, just based on discussions that I've had with the accounting team so far, that by the time you get to September 30th, you'll likely have recognized all of that funding as revenue. I do have a call with your accounting team this afternoon to talk more specifically about that, because they're in the process of working through all of the documentation that will be necessary to demonstrate what your lost revenue and COVID-specific expenses have been.
Right. I agree with you, but my challenge has always been, the other revenue is the correct way of doing it. I don't see anything on the liability side. And is it safe for us to go ahead and book it and release them as the number become more visible to us? Because not having that line create a problem for me personally.
Yeah, I certainly think it's appropriate to go ahead and recognize the revenue as you are able to measure that that you have the lost revenue or that you've met the other eligibility requirements. In a lot of the FAQs that have been released by the federal government, they've been very clear that they don't want to put a lot of strings. They don't want to attach a lot of strings to this funding, and they are intentionally making the measurement, I think, fairly broad and gray. And I also don't think that you're going to see a situation where you get any sort of formal communication from the government that releases you from any liability related to this, because the process is going to be that you're going to receive the funding. If you believe that you've been overpaid, it's your responsibility as an organization to note that and repay those funds. But then the funds are going to be subject to single audit. And so when we perform the single audit for fiscal 20, we'll have to address that question and as an auditor, basically confirm that that all of the funding that you've received was due you based on the terms of the CARES Act.
Uh-huh. So let me simplify that. So we should put some liability on the balance sheet as a liability as of today with the visibility that we have.
Sharon, do you want to speak to that? Because I don't know what all steps have been taken internally yet to measure that.
So currently, with the 8.2 million, we have lost revenues in excess of that 8.2 million. So from that standpoint, the first relief fund payment that we have on our books right now, we could support that 8.2. As we receive further payments through different mechanisms, we will park those on the balance sheet until we get through some of these further discussions as those numbers get larger with BKD. It is important for us to make sure that as we approach the single audit, which is outside the financial audit for governmental funds, we want to make sure that BKD and JPS is on the same page with that, so that we don't have any questions by the time that audit occurs. So I'm comfortable with the 8.2 million as it's recognized as revenue today. But as we receive more and more funds, again, there's lots of questions on the measurement date. How you look at it, it's not black and white. It's not a formula that you can put together and say, yes, we can recognize this component. It's more overarching than that. Along with the COVID funds, we also have potential FEMA reimbursement that also has to be looked at as we recognize the COVID and apply for the FEMA reimbursement. So there's a lot of moving parts right now.
Mm-hmm. But the question is it safe to go ahead and book some for liability versus not booking anything? It's also the same practice. Like, sometimes we book bad debt, but then you recognize and remove them as you don't have that much bad debt. But from not booking it, I don't know if that's the right thing to do. But I'll rely on you guys to do it. But I would strongly suggest that we take a look at it closely to see it. It's safer to put it there and remove it than not putting it at all.
So based on our conversations from last finance committee, I have footnoted at the bottom of both the Acclaim organization as well as the JPS financial statements that we have recognized those funds. So it is footnoted that those are in our revenues at this point in time. Again, the 8.2 million is a relatively low number for this COVID impact financially that we've experienced.
And I would say as auditor, if we were to come in at 9:30 and you had not recognized that revenue, but we looked at a measurement of your lost revenue and saw that your lost revenue was $15 or $20 million, but you had not recognized that $8 million liability, we would make the recommendation that revenue be recognized because you've in effect met the eligibility requirements to keep those funds.
There's a big difference for me from being conservative in nature versus being aggressive in nature. I think this is where we fundamentally have a challenge.
If it was a larger amount than the 8.2 million, I would feel like that might be aggressive, but the 8.2, in my opinion, we're not on the aggressive edge of that. I think it's a very reasonable number to assume that we have lost 8.2 million of revenue or incurred 8.2 million of expenses to date.
All right. I guess I don't see the detailed numbers, so I think you answer all the questions that I have. Thank you, Chris. Thank you, Mr. Chair.
Thank you, DT. Thank you, Chris. Any other questions for Chris or for Sharon on this item? Hearing none. Thank you, Chris. We appreciate your participation in this today.
Yeah, absolutely.
Steve, there's one other item that we wanted to cover while Chris was on the phone, and that's to talk about the resolution that was presented at the last meeting for the forgiveness of the acclaimed debt on the medical center statements.
My apologies. Yes. Go ahead.
Sure. So on that particular issue, we've raised that question with Sharon in the past as we saw the balance of the amounts due from a claim to JPS grow over the years. And I'll say that this scenario is very consistent with what we see in the industry. Most health systems have a large physician group that, from a financial reporting perspective, loses money each year. The benefit of that is in the revenue that you see on the hospital side. And so naturally, because the hospital continues to fund those losses, there's this due to, due from that exists between the two organizations. And that balance has a tendency to grow over time because the physician group is not generating the necessary cash flow to pay back those amounts. And that's all part of the strategy of the organization and is normal, certainly here in Texas. The issue arises only because from a consolidated perspective, it doesn't matter because these balances are eliminated and they don't get reflected in your consolidated financial statements. But in the footnotes to the financial statements, GASB requires that we show a consolidating schedule that shows a claim activity separate from JPS activity. And in that schedule, we see the amounts due to and due from on both entities. And our concern is that because those balances won't likely be paid back, that in that footnote, we're reporting balances that are really not accurate because those intercompany balances can't be satisfied. And so our recommendation is that you consider writing those balances off and each year go through that process of essentially transferring equity from JPS to a claim. And the way that gets accounted for under GASB reporting standards is as a transfer, and transfers and special items like that go essentially below the line. So in your income statement, you've got operating revenues, operating expenses, and then non-operating revenues and expenses. But below that section, you account for special items and things that are really more equity oriented. And so our recommendation is that you essentially forgive that debt from JPS to, or from a claim to JPS, and show that as a transfer of equity between the two organizations. This doesn't result in any sort of investments or equity method investment on JPS balance sheet that would misstate the JPS financial statements. It simply is a forgiveness of debt that is accomplished through a transfer of the net position between the two organizations. So I'd be happy to answer any specific questions on
the committee's information. This is an item that's coming up later on the agenda, but since we have Chris here, we can maybe talk about it, and then it'll come up later on the agenda. So if anybody have questions for Chris on this item?
Yeah, I do.
Yes, ma'am.
It's when you do the audit report, where do I see that number? Where do we monitor that amount? Is that the same amount that I see that's in the budget that comes across every month? Is that the exact same amount that we would be forgiven? Like they have their budget, and on the deal, we see what their loss was every month. Is that the same amount that would be?
Yes, ma'am. We're talking about the same issue. Now, the amount that we're talking about to begin with, and I can't remember what the exact balances are as of today, because there's a large amount due between the two organizations. So that would be a starting point. But then in subsequent months or subsequent years, the amount that you would essentially be forgiving is that loss that you see on their financial statements. Now, there could be a little bit of a difference each year, because the loss that you see in the income statement is not necessarily reflective of the actual cash that's required to fund that loss, because there's things like depreciation, non-cash related items that end up impacting the net income. But it should be a good measure of how much you would have to transfer each year to satisfy this issue.
Okay. All right. And when we do the resolution, is that something, Sharon, that you would tell us once a year what it is? Or is this just going to be done behind the scene and we wouldn't have any way of knowing it?
No, ma'am. I can bring that back to you at each year end as we present the final year end report. And currently, Chris mentioned the balance as it is today. Remember, a claim's been going for more than 4 years now, and that balance is about $87.9 million, about $20 million a year from a cash flow deficit standpoint. So the resolution that we'll be looking at later actually allows the annual transfer from the receivable into the equity section of our balance sheet. But I will definitely make that a year-end report out to show you the exact cash, but it will be very close to that operating loss that you see on a monthly basis.
All right. Thank you.
Go forward basis in your audit report, in that consolidating schedule that I mentioned that's in the footnotes, you'll see that transfer each year and what that total amount is.
Any other questions for Chris? Okay. Okay, Sharon, now can we let Chris go?
Sir, thank you.
Thank you, Chris. Appreciate your help. Anything remaining in your report, Sharon?
No, sir. Thank you for the time.
We'll move to item 5, which is 5A, which is the unaudited financial reports from the June 2020 month. Sharon.
Thank you. If we could pull up the financials for June. And on the second page, I will say that June, we are continuing through the pandemic. You will see much the same that we saw for April and May coming through from, although volumes are returning slightly, the financial picture is not completely different with special staffing. Our ICU is still a higher mix from an inpatient standpoint, and a claim as well is almost identical to the 2 previous months. So if you go to the second page of the financials, one more, you can see that our admissions are still slightly down, but as I mentioned before, we have a much higher acuity that is occurring. At the bottom left of that page, you can see that our case mix index is up by 7.3%. That's a reflection, again, of just how sick the patients are. And that has been in excess of our normalized budget amount for April, May, and June, as you can see by those blue bars. Our length of stay, it's counterintuitive, but our length of stay is actually down by 8%. In normal times, as you see that CMI ramp up, you would also expect patients to stay in the hospital longer, but we are doing a really good job of managing our patient beds and flow. We have a lot of outpatient programs that are allowing these very sick inpatients to get back into a home environment, and it also helps protect the patients that are here as an inpatient at the hospital. So we've done yeoman's work on patient turnover there. The next page shows a little bit about what's happening with our... Yes, sir.
Quick question for you on the CMI for the month. It's creeping up. It's not because of COVID-19, is it? Or is it just a standard more severity on the patient? You know?
I think it's a combination of both. Many of our COVID patients end up in an ICU setting, which ranks at a higher CMI than a general medical or surgical patient would be. So if you look at total admissions, they appear to be a little bit down, but we do have a heavier weighting into ICU. And I think a lot of that has to do with opening up a new COVID unit that was not existent in March. And all of those patients are incredibly severe as well.
Okay, thank you.
You bet. So from an emergency department standpoint, you'll notice that looking at the blue line again in the top left, April, we saw a tremendous fall in our emergency department visits. And I think as we start a slower recovery, we've seen an uptick. We are still about 12% down from a budgeted amount. Our urgent care visits are also slowly trending up since April. Those are still only about 2/3 of a normal level. If you look at our primary and specialty visits, what we've done with these, you'll see a big uptick, and there's 2 reasons for that. The first, we did have a reopening phase 1 where we were opening up schedules and trying to fill as many face-to-face visits as possible. The other thing that we've done is we have included those telehealth visits that we were talking about. So we actually can charge for those visits on the medical center side through July with that connection fee. And that helps give a better representation of the actual patient touches that we're having. I will say that telehealth does comprise quite a bit of the volume at a clinic setting for the last couple of months. And we will be talking a lot more about telehealth and the financial impacts tomorrow during some of our budget workshop discussions. But you can see that it appears to be almost back to normal levels, but a very large part of that bar is actually telehealth touches. The next page, really looking at the surgeries at the bottom. Our inpatient surgeries are down about 16%. And then you'll notice an uptick in the outpatient surgeries as we start to reopen for elective cases. That's down on a very limited basis, but still below our normal levels quite a bit. On the next page, we have our mental health activity. Psychiatric patient days are down about 12%, equal to last month. Our psych clinic visits are about right on budget. Those have remained constant and consistent through the pandemic. Our psych ED visits, we have seen a spike in the last 2 months, just based on patients coming into our facilities seeking treatment there. The next slide is more financially focused, some of our key metrics. Our days cash on hand, you can see that that is not following our normal 3-year trend line. If you recall, back in April, May, and June, we have been receiving some COVID relief funds. We've gotten payments for self-pay patients through HRSA that have been identified and diagnosed with COVID. And we also received $50 million of Medicare advanced payment. Now, the Medicare advanced payment, again, as a reminder, that is truly a liability. Medicare, in anticipation that hospitals may have cash flow issues through the pandemic, effectively loaned us that money. And as they process our claims beginning in December, January, February, we will have a slow repayment of that 49.5, but those I feel certain will be earned over time. So we kind of got a cash inflow, and that has a lot to do with that high number. At the end of June, we were at 271 days that were available for operations. We're watching our accounts receivable very closely. At the end of June, we were at 42 days of AR. And someone asked the question during the last presentation last month, what is a day worth in our accounts receivable? It varies quite a bit, but on average, that's about $1 million worth of cash. So if it goes up by 2 days, it's around $2 million use of cash. And as we can whittle that down to the low amount, and 42 is fairly low, we gain about $1 million of cash. Our FTEs per APD down at the bottom right, that is unfavorable. These are year-to-date numbers compared to our budget. So right now we're running just over 6 FTEs per adjusted patient day, and our budget is at 5.6. Remember, this calculation has volumes as the denominator. So as volumes fall, that number becomes unfavorable very quickly. You'll go 2 slides. Are there any questions on the key statistics that I just covered? It's hard not seeing your faces here. So Jps Connection Enrollment, we have made small upticks in our enrollment numbers. I believe one of the Finance Committee members brought up a concern that had bubbled up through to her personally. And I wanted to report back to the committee on what our findings were for 2 patients that were denied the connection enrollment entrance based on the relief payment of $1,200 and the $600 inflated unemployment payment. The policy that we adopted back in March was that we would not include these inflated payments as part of the financial requirement for entrance. After we followed up, a mistake was made by the staff person who was evaluating this, and those people were immediately notified and allowed connection enrollment. But the bigger picture was, did that happen to anyone else? Even though we had training, even though we had communicated that in many different forms, and that our employees have signed off based on that training, we went back and we looked at all applicants April through June, and that was about 7,700 applications during that time period. There were 1,800 that were denied coverage, and about 10% of that, or 185, were denied because of income. We reviewed each one of those very carefully, and there were 2 more applicants that were incorrectly denied, so they were notified. And we've got a new process in place, especially during this exception period, where if you are denied because of income, we're having a supervisor or management review of that before it's communicated back. So even though that is a 0.05% error rate, I do want to make sure that, it's a very important error if it's personally impacting a patient. So I just wanted to follow up on that since it was a discussion from last time.
Sharon, in doing your research on those that were denied, did they go any farther to find out if it caused any kind of hardship on those persons because they were denied, that they didn't get a service or get treatment based on that?
So we adopted a policy shortly after I arrived. So it's probably been here 3.5 or 4 years, where we have a retroactive coverage for connection benefits. So if they were on site, which is how most of our connection enrollees come to us, then those claims would be taken care of as if they were a connection member at that time.
Okay.
Any other questions on the connection enrollment? I will report also that we have had an uptick in July for applicants. It had trended down for April and May. June was about at a normal level at around 4,400, and July looks like it will be a much busier month as far as processing. So if you flip to the next page. So for the month of June, the medical center, again, volumes were down. We had negative impacts in our operating revenue, but we also had savings in some expense categories that more than offset that. When you look at net patient service revenue, we were down about $724,000. We also, as in the past months, we've had communication through the appraisal district that we had appeals that property owners had filed that were settled. And we had to reduce our property tax revenue by about $600,000 from budget in June as well. So that puts us under budget for operating revenue by about 1.6%, or $1.4 million. You can see that we had some savings in our salaries and related expenses by about 2%, or $926,000. A lot of that is, again, because of decreased volumes, but we're also having some savings in our benefits area. Part of that was in our employee health, and part of that was in tuition assistance. The tuition assistance could be timing. So we'll give that a couple of months and see where we end up year to date. The largest underage is in purchase service at 3.5 million. A lot of this, again, because volumes are down throughout our clinic population, and as well as inpatient. We've had savings on coverage fees. We've had savings on claims paid. And we also had about $1 million that we were able to recoup for overpayment from a prior period. So about a little over 2 million of that is actually related to volume. Our supplies are down because surgeries are down. That's a very expensive supply area. And of course, a lot of our clinics are down as well. So we had about a $5.6 million savings, almost 7%. And that produced income from operations of 8.9 million compared to a budget of 4.8 million. Year to date, that income from operations is 60.1 million compared to a budget of 46.2. Again, DT, I did have an asterisk up on the year-to-date side of other operating revenue, just to remind everybody that we do have currently that 8.2 million in relief funds recorded.
Quick question, Sharon, on the supply side.
Yeah.
I'm not sure what kind of GPO contract that we have. Usually it's based on volume. Do we have the risk of a repricing at a high price if we don't hit a certain volume at the end of the year?
So I can follow up on that. I don't know that I have all of the information today. What I do know we have been experiencing is a repricing because of supply shortages with our normal vendors. So things are becoming more expensive. I don't know that we have any opportunity losses on declined volumes of purchases, but I can have my team look at that and report to you at the next finance committee.
That'll be great. I hope not, but
yeah.
Thank you.
Yeah. So our last conversation. Yeah, it is. Our last conversation with one of our suppliers is a lot of them had been honoring the pre-COVID price, but we're beginning to start to see on some of those PPE items that they are beginning to charge higher prices for the allocation that we used to receive historically. So there are some price adjustments out there in the market. If you flip on about 3 pages to the next charts, there you go. Our billed encounters for the month on a claim are down about 17%. Year to date, they're down about 13%. Many of the providers within a claim are primary care, outpatient focused. So this bar chart looks a lot like our clinic volumes on a prior page. If you'll go 2 pages, please. The income for a claim for June, again, was...
Sharon, the bill encounter, is that?
Yes.
I'm assuming that does include also the telehealth on there also as well. Right?
I'm sorry, they include...
The telehealth claim?
Yes, they do. These billed encounters do include the telehealth on the claim side.
Oh, I see. Do you know roughly the percentage? Doesn't have to be exact, but for the telehealth out of those transactions?
I did have that. Let me continue to look through my notes. I want to say the way that I looked at it was on the outpatient. So I don't know what percentage of the total is of the right now we're looking at 68,358. We're seeing around 20,000 total telehealth. So about a third of those would be in the ballpark.
Oh, I see. So we'll probably have a third offset by facility fee.
Yeah, and I'm going to go into that tomorrow as we talk about the financial impacts for 2021 on telehealth. It's a very complex change, as you're alluding to. Yes, okay. Sir.
All right, thank you.
Mm-hmm. So, you know, with the decline in encounters, we have a loss of revenue of about 1.7 million for the month on a claim compared to our budget. And it's not only impacted by encounters, but the telehealth payments that we are receiving are less than half of what a face-to-face visit would reimburse. So there's also a lot of a mixed change that's occurring in this reimbursement in the net patient service revenue, or what we expect to collect from the visits this month.
So it's less payment, not just absent the facility fee and all that, but actually for the provider themselves, it's a lower fee they're being paid.
It is a lower fee. There's, for Medicare and Medicaid, we had a temporary grant, a temporary period where they would actually pay for a telehealth visit like they did a face-to-face visit. Now, that was not for commercial payers. It was just really for Medicare and Medicaid. Maybe we've gotten a few commercial payments at a higher rate, but that program is scheduled to end at the end of July and has not to date been extended. So we'll be following that very closely, but when we talk about budget tomorrow, we will be we'll not be budgeting a higher rate, since it's not a guarantee. We'll actually be budgeting for the lower reimbursement, both on the medical center as well as a claim. So we ended up about $2 million behind, or about 18% in revenue. If you look down at the bottom half, we did have some savings in operating expenses, but only about $500,000. So a claim lost about 3.5 million compared to 2.1 million budget this month. Next page. When you look at this as a combined total, however, our month on the left side of the page, from a combined standpoint, our income was 5.1 million. When you take the medical center, a claim, and the foundation together, compared to a budget of 2.7 million. So we are able to perform well on a combined basis. I think that's also important to note that if you have a lot of healthcare background, or if you hear about facilities, other facilities that have a 5% self-pay mix, we have a 40% self-pay mix or uninsured population. For a lot of those facilities that you hear about, as their volume drops, their revenue had significantly dropped on the medical center side. Ours is buffered a bit when we have a fall in volume, when 40% of those we were not receiving payments on before COVID. So it's not favorable, and I don't mean to imply that, but it is a different look at a public facility with a 40% payer mix than it is with a not-for-profit facility that may carry about a 5% self-pay mix. So, and I do think that once we start to up-ramp some of the outpatient areas, when we can do that based on some of the stay-at-home orders and the social distancing, we'll start to see some of those expenses return. Are there any questions on the June financials that I can answer for anyone?
I had one question, and this is just it's probably, I missed it somewhere, but in your explanations on one of the salary related expenses, it was payment for research revenue earned by physicians and research coordination. When they do research, aren't they, that's an expense that's covered by that study, right? And that's just a recording of it.
So I think from that standpoint, we have I'm sorry, I'm getting a lot of echo again. I think from a timing standpoint, we reconcile some of those grant and study monies. And so that may have been more of a 3 or 6 month catch up, a one-time payment for that volume. And Dorothy, I will confirm that and let you know. Any other questions?
Okay, I would entertain a motion to accept the financial report from June. Do I hear a motion?
Move for approval.
Motion by DT.
Second.
Second by Dr. Weber. All in favor of accepting the report, please say aye.
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 Opposed? Motion passes. Thank you, everyone. We'll move on to item B that we mentioned earlier about the reclassification of debt.
So this is just a reclassification for financial purposes. As I mentioned earlier, the current balance at the end of June is $87.9 million. And Dorothy, to your point, we will be bringing that annualized amount back to you during our September 30th financial discussion at the end of each year.
All right, thank you.
Mm-hmm.
And is it, to Dorothy's point, can we make it, or does it make sense, I don't have the language in front of me, to make that part of our motion that we get an annual report on this, that it doesn't somehow over time we kind of forget about it, but it's a part of our annual report to the board?
I would defer to Neil on that, but I think that we could amend this resolution to reflect that.
Well, I would agree with Steve that if we add that, then I'm more in line to approve it, okay?
Neil, do you see any issues with incorporating that into the resolution?
No, and I'll be happy to do that, and I'll have that available to be approved at the board meeting, okay?
This is Charlie. I hear your motion.
All right, thank you, Charlie. We'll take that motion.
I think did Dorothy make her motion?
Did you?
I didn't make the motion. I was just saying I agreed with Steve, but
okay.
That as long as the resolution is being changed to reflect an annual report of it to us, I am okay with the motion.
Then based upon that amendment being included in the resolution, and Ralph, I'm going to say this out loud. I think I was the first chair of a claim because you were chair of the board and vice chair. I would make a motion that this, along with the amendment that's being included with annual response back to the board, I make a motion for approval.
We have a motion.
Second. DT.
Second by DT. Any further discussion? All in favor of the motion, please say aye.
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 Opposed? There being none, a motion's approved. Thank you all. All right, we'll move to item 5C, Ms. Clark.
Hi, this is a renewal for our large GPO contract, which is a group purchasing organization. And as DT alluded to, he gave me a nice segue into this contract today. We have gone out for RFP on this GPO, and a GPO allows us to kind of the philosophy behind the savings is that you funnel dollars through certain preferred vendor contracts you actually receive your supplies at a lower cost than you would be able to if you were to go out and negotiate for medical, pharmaceutical, and office supplies by yourself as a hospital. We sent an RFP out. This was a very large undertaking for our organization. As you can imagine, it impacts almost every area of the hospital. And after the evaluation, our incumbent Vizient was awarded or suggested to be awarded the contract. It is a possible 5-year contract. It's 3 years with 2 one-year renewals, although there is a 120-day out clause. We spent last year about $85 million through the Vizient GPO vendors. At the end of the day, what Vizient gets out of this is a net 1%, or about $816,000, which is what I've shown here on the cost for this contract. And over those 5 years, that would be about $4.7 million. From our current contract, we have a couple of benefits that were big wins for us. We have gotten 3 pieces of software at a highly reduced rate, in most cases at no charge, for some savings actualizers, both in our pharmaceutical and our supply areas, and a product called Data Links, which helps us maintain very important vendor master files and tracking. So that's 3 separate software licenses. And then on top of that, we are conservatively estimating that that will produce about $1 million worth of savings annually, with some of the new philosophy behind what we're doing there. I'll be happy to take any questions.
Any questions for Sharon?
I have a quick question on the 1% GPO spent after rebate. So the rebate goes to us, or?
So the net 1% is after our rebate. So we pay kind of, I'm sure you're probably more familiar than most of how GPOs might work in healthcare, but you have a certain percentage that the GPO actually takes, and then they rebate a large amount back to the facility. So that 1% is the net.
Oh, I see. Okay.
Yes, sir.
That's a good appreciation.
Any other questions? Charlie, look like you're getting ready to ask one.
I just have a quick question for our general counsel. Is it safe for me to recuse myself from this one, or can I vote?
Do you have a relationship with Vizient or one of your companies?
I don't, but I used to run as the president of MedAsset. That division is MedAsset division, a long time ago.
But that's been in a previous life. That's not currently.
Right.
No, then you would not have a conflict.
Okay. Yeah, thank you.
Hey, Steve.
Yes, sir.
I've just got one question. I'm certainly for this. It's not negative. I think it saves us money. And if Robert's there, I know he's been in and out a little bit, but if didn't we have a GPO, or Sharon, you may recall, did the foundation, I'm trying to recall something a few years ago.
Yes.
Wasn't there some GPO or buying capacity we had to use foundation or the owner? I'm just going from memory, so I don't get.
So yes, you're correct, Charlie. That was a tough time trying to figure out how to account and hold that. What happened is some of the rebates that we had been receiving through Vizient, it was more of a business transaction. They merged with another large GPO, and they wanted to, it turned into a stock transaction versus a rebate. So the foundation is holding some of our benefit from that transaction and stock.
So, but this is strictly for the hospital here.
Yes, this is, we're only talking about the contract to access the better pricing with vendors here today.
Thank you. Thank you, Sharon.
Mm-hmm.
Thanks, Charlie.
On this contract, this will help the directors to be able to see if any diverse companies can provide that, and your department or whoever's auditing will be able to see that information if I'm reading their information correct, right?
Yes, and we're going to talk about one of those vendors on the next section with our office supplies. So yeah, they do a good job about offering minority spend vendors. And we do that with our office supplies that you're going to vote on in the next contract.
All right, thanks.
Okay, any other questions for Ms. Clark? Entertain a motion.
Approval.
Motion by Mr. Bose.
Second.
Second by Dr. Weber. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you.
So this next contract is with a company called Guy Brown. It is a Vizient vendor for our all of our office supplies. We've had Guy Brown for some period of time. The estimated annual normal spend is about $880,000 a year. The timing of this contract is a little odd, and I just wanted to tell you why we're suggesting a 40-month term. Their contract with Vizient is tied to that 40-month term. So we've made this timing so that when our contract with them is the same timing as their contract with Vizient. But it does have, the initial term is 16 months with 2 one-year renewals. So if we stayed with that 40-month term, the spend would be about $3 million. They are the preferred minority spend vendor participating within Vizient, and there is a 60-day no-cause term.
Any questions for Sharon? Entertain a motion.
Move approval.
Motion by Mr.
Charlie,
Bose.
I'll second it. I had to get my mic on.
Second by Mr. Powell. Any further discussion or questions? All in favor, please say aye.
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 Opposed? There being none, motion passes. Thank you. All right. What's our next item here?
We're going to be talking about a GEP
item
contract.
F. No, sorry, item
E.
E. Sorry.
That's okay.
Counseling.
Item E. Was there a comment? Okay. Item E is with a firm called GEP. Back in April, we were able to obtain their services for 90 days as we started to deal with supply chain, logistics, and procurement during the COVID pandemic. We are asking for a 4-month extension to that contract to also help us. We've had some changes in personnel in the materials world. Also, our supply chain director, who is great, but has only been with JPS for about 2.5 months now, really needs that infrastructure behind them. I've got to fly, sorry. This contract allows 3 full-time dedicated individuals in a senior manager, a senior associate, as well as an associate It also gives us the ability to reach out to their subject matter experts, and the relationship partner is also accessible during this extended term. We are asking for $392,000 for this service.
Mr. Chairman, I will say, in addition to comments that you made, you all granted, some of you voted against this, and I appreciate y'all's concerns, but I will say that we meet with a week, and the company has been a good company. In Florida, I met with before Florida became the hottest spot, second only, first and second to Texas. But they've been a good group to work with. They have allowed us to streamline a lot of the functions and duties that we have in materials management. And I think it's been greatly needed in the JPS organization. So all I can say is, thus far for 90 days, the organization, which we did not know going into this, has been very beneficial to us.
Any questions for either Sharon or Robert?
I have a question. Now I see the first program, Sharon, is on your schedule too. That's for the 4 months. Then I got another schedule 2, fees and expense. Is that from the previous one, or are we renewing this one too?
Oh, sorry.
Okay.
Good person, and then I forget. So my apologies. So the schedule 2 that applies to this is a 4-month plan that extends the first 90-day plan. Was that your question?
Okay. Oh, all right. Let me see if I understand that. You're extending this one for 4 months. That increases this $98,000, but we also are extending the $120,000 a month for the other one, because I got 2 Schedule 2s in my book.
Okay, I apologize. The $120,000 a month was for the first 90 days.
Oh, okay.
Yeah, right. So we are extending at a lower rate for 4 months at $98,000 a month. Yes, ma'am.
That was my clarification. All right.
Yeah, sorry for that confusion.
Okay.
This is actually, Dorothy, a First Amendment to that previous contract.
That's why I had both of them. Oh, okay. Well, that's all I was trying to clarify. All right.
Thanks.
Any other questions for Sharon or Robert? I will entertain a motion on item E.
Mr. Chairman, this will require 2 parts too. This will require 2 parts.
Thank you, Counselor. Yes, so this is a 2-part
contract.
Correct. So, Mr. Powell, is that part of your motion?
I'll make it part of mine.
Oh, Mr. Zimmerman. I don't see your pretty face on our screen.
But that's why you don't see it. So you think it's pretty.
Motion by Mr. Zimmerman. Do I hear a second?
Second.
Second by Mr. Bose. Any further discussion or questions? Hearing none, all in favor of the motion, please signify by saying aye.
Aye.
Opposed? Motion passes unanimously. Thank you. All right, well, let's move to item F. Ms. Clark, you're still up at bat.
I am, and I know you're going to be disappointed that other folks are now going to be presenting after me their contract. So I think this is my last one for today.
We're going to miss you.
I'll see you tomorrow. Okay, the last contract I have today is with BKD. If you guys remember, we went out for RFP about 3 years ago to look at accounting services and to evaluate firms that may be out there that could complete a public hospital external audit. There were a few respondents. A couple of them priced themselves way out of the running. We interviewed 3 firms. One of them, and well, actually both of the other firms did not have a good handle on the complexities of the supplemental funding, or did not have any public hospital experience, whether it was in Texas or out of state. So we awarded BKD the audit for a 3-year term, and we're at the end of that term, and I would like to renew a 3-year contract for 2021 and 22 fiscal years. They have held their fees equivalent to the prior year, so $192,000 for each of the next 3 years, or a total of $576,000. We are actually exempted from having to bid this as a professional service, but we have done so fairly recently. Are there any questions that I can answer for you on BKD?
Karen, I know I sent you something, and I just want to go on record of saying, when we get requests and I look at their form that says they have no intention of doing any, they always say we can't do anything, but they don't share anything like we are trying or have any plan to bring in a diversity of vendors to work with us. I just think that they're saying to me, we need to push that we want companies that's going to work toward helping us meet our goal. Okay. So did you find out anything from him after?
Yes, ma'am. I did, and I apologize. I texted you this morning, so it may not have gone through. To address Dorothy's concern, I have had conversations with Chris in the last 24 hours, and BKD does have a program where they will partner with a minority firm, and that minority firm will provide staffing and become part of that BKD team for our financial audit. And so if you would like to make that as a recommendation, BKD can incorporate that into the 3-year contract. Dorothy, you're not coming through.
You're muted, Dorothy.
Yes, I would like to make that as a recommendation, because I think we need to start putting an emphasis on ensuring that companies work with us. And by putting it into motion, that would mean Sharon will have a way to follow up and make sure that it actually happens. Okay?
Thank you.
No company should tell us, oh, you can't do that, but I think that should be a requirement.
But I didn't hear you.
I said, while my system's not working, I act like if I sit closer to my face. I think that should be definitely a requirement in every contract. I'm offended when companies say, sorry, I can't do that. That doesn't seem to be an answer that's viable. So I think you should establish the aspects of doing it. It should be done with everybody and give us tools and the ability to fight. So thank you. I appreciate that.
And Dorothy, we can modify the contract prior to signature and just put a clause in there for the inclusion of minority participation. That should not be a problem.
And I haven't had a chance to read my texts this morning.
That's okay. That's all right.
Okay, thanks.
Is it possible for them to use the people more in the Tarrant County area, if they can help it?
No, with my conversations, BKD's offices, it might be the DFW Metroplex, but I do know that he mentioned they have a couple of firms that they will work with, and it just depends on what the availability of the staff is on which firm that they may select. But they would be in the DFW Metroplex. I can confirm that.
Oh, I see. try to find out see if we can benefit for the county area.
You bet.
For us.
I will ask him about that. I don't know that it might restrict him if we tried to put it in the contract itself, if the Tarrant County firms don't have staffing available.
Sharon, one question I have in that area, I know BKD said they would, they have minority firms that they would contract with, but will we still ask them to look at the percentage that we have on record, the 25%?
We can talk. When I asked Chris about it, typically the hours as they work out through the staffing is somewhere between 15 and 20% is the typical minority participation when we elect to go that way. So I don't know that we can require the 25% because as the firm, they elevate certain, there's staff and then managers and there's partner reviews and concurring partner reviews. So I can check with him and ask him what the maximum he would be comfortable with as a guarantee in the contract, but also express that we would like to see as much as possible.
Reverend,
go ahead.
Reverend Emerson, I think what might help is I do not mind at all calling the principals of BKD and having that be a CEO to sort of CEO conversation and let them know as a public hospital, that's incredibly meaningful to us. And to some of your other clients who are either publicly traded or private corporations, it may not be, but for us it is. So I don't mind having that conversation and telling them that we will watch very closely to see if you can begin to start hitting these goals, because they're goals at JPS and they should be goals with every vendor we have.
Yeah, I appreciate that, because I don't want them to say, well, we'll try, because I don't want you to do a token thing with us.
Exactly.
So that's what my concern is. Okay.
Yes, sir. I will communicate with their CEO and I'll communicate back to the finance committee and tell you all, one, how that call went, and two, I think it's best to take BKD and every vendor and put them on some type of a we're watching you basis. So we'll be happy to. I will give you an update, Reverend, and the other.
Okay.
Agreed. There's no trying at JPS. We do it.
Yeah. Can I, since we are asking for an exception and giving them another 3 years, as we go through this, if they come back and say, no, we can't do but 5, I'm not sure I want to commit us to 3 years. So could we find that out before we do the exception and then give them another 3 years without going out to,
So just a clarification, this is not an exception to bid. Professional services don't require bidding, but as a practice, we go out every 5 or 6 years for bid. It does have a 30-day no cause term. So even though it's a 3-year contract, we can term it at any point in time. Of course, we have to manage that with the audit.
Yeah.
But,
okay. Well, I just sort of want to make sure that they realize the seriousness. Folks can lip service, but if you're saying this is important to us, I'm not willing to say, okay, if you come back and say 5, okay, we're okay with that. That's where I am with that.
No,
okay.
I can assure you that'll be part of my conversation when I talk to the CEO of BKD, to just let them know that one is important to us. We're not locked into third.
Okay. All right.
And Dorothy, I'll know this still has to go to the full board, so we can ask those questions at the next full board meeting before we approve it. So
yes.
Any other questions for Sharon or Robert on this item?
So if it doesn't work out, we can hold the chair of the finance committee accountable.
I'm sorry, Reverend, you were muted then.
I move for approval.
We have a motion by Mr. Nguyen Do I hear a second?
How to hold the chair accountable. I'm just
Was that part of the motion? I don't know. I heard a second, but I didn't hear the voice.
Second.
Who was that?
Reverend Emerson.
Reverend Emerson, thank you very much. So we have a motion and a second. All in favor of the motion, say aye. And that's a two-part motion, correct? Or no, it's not a two-part. Sorry. We have a motion and a second. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Ms. Clark. You can go get you some water or something now. Item G, Ms. Peebles. There she is. Haven't seen you in forever.
Good morning. How's everyone? Can you hear me?
Yes, ma'am, we can. Thank you.
Great. Thank you. I'm here this morning to ask your approval to consider an exception to bid and then approval of a purchase agreement between Mermaid Medical and the hospital district. This is for an angel catheter, and the angel catheter is a sole source through this company. And what this is, it's a central venous catheter that's combined with an inferior vena cava filter that the physicians can insert at the bedside to prevent pulmonary embolism in patients, specifically patients who are at high risk for these blood clots. And the reason we're asking for this is that many of these patients, specifically traumas and all, if they are not candidates for anticoagulants, for specifically like if they have a brain bleed or something like that, you don't want to be giving them an anticoagulant. So by the use of putting this filter in, it can prevent the blood clot from moving or going. And so our surgeons are asking to use this catheter. So it's $117,500 annually. It is part of our approved budget. It's a 3-year contract. The alternative to this, if the patients perhaps did not have this, and they did develop a clot, what would happen is we would have to give them TPA, and that's like $25,000 an injection. So this is a much lesser expense, and it also is a great protection for these patients who are at very high risk for increased morbidity and mortality.
Any questions for Ms. Wanda?
Yes, sir. I have a question. Is this the only vendor that we can choose, or is it because of the PPI?
No, it is the only vendor that makes this specific catheter.
Okay. All right. Well, I thought, Wanda, you remember when they do the gastro surgeries, they used to put in filters to kind of protect the patients. Is this, they put filters in before to kind of stop a clot. So this is different that they can do it at the bedside. The other one would have to be inserted. They used to do it in radiology. So this is a bedside procedure the physician could do right there at the bedside. Okay.
Sort of like putting in a central line.
Okay.
Any other questions from Ms. Peebles? And this would be if the committee elects to pass this. This is a two-part motion. Do I hear such a motion?
So moved, Trent.
Motion by Mr. Petty.
Second by
Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Thank you. Opposed? Motion passes. Thank you. Wanda?
Thank you so much.
Item H has been requested to be pulled from the agenda by administration. I think we'll bring that back later. We'll move to item I. Dr. Duncan.
Hi, good morning.
Good morning.
Can you hear me?
Yes, we can.
Okay. I'm coming before you to ask approval for exemption to bid and also approval of the purchase agreement between Climatech and the district. As many of you know, paramount to maintaining a safe OR environment is the accurate monitoring of temperature, pressure, and humidity. Currently, our ORs have 2 different HVAC controls and monitoring systems. Without getting into too much detail, we currently have Andover controls and Allerton monitoring. Angie Morgan gives me the analogy that that's much like having Ford and Chevy parts trying to work together. Syncing the 2 systems has become labor intensive and, more importantly, has been identified as a regulatory risk. So with your approval, Climatech will come in and replace the Andover controls with our Allerton controls, and that will allow us to place both our monitoring and our controls on the same system. Currently, we have Allerton controls in about 90% of our buildings, so this will help standardize our building controls. I'm also asking for exemption to bid. Climatech is the only North Texas dealer of Allerton controls. It is local, and it is in good standing here at JPS with servicing our systems. So I'm asking for approval, both exemption to bid and for the purchase agreement between Climatech and the district.
Thank you, Karen. Any questions for Dr. Duncan? If there being none, I'll entertain a motion.
This is Zim. I move to provide the exemption and approve the proposal.
Thank you, sir. Motion by Mr. Zimmerman. Do we hear a second?
Second.
Second by Mr. Bose. All in favor of the motion, please say aye.
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 Opposed? Motion passes.
Thank you.
Dr. Duncan, let's move. Item J has the request has been to remove that from the agenda as well. We'll bring that back later. Move to item K, Dr. Duncan.
Actually, Rob, are you on?
I am.
Okay.
So,
Dr. Steve.
Yes. So this is. Thank you so much for allowing me to present this. This is my maiden voyage in contract proposals. So please bear with me just a moment. So this is a.
We can haze you, Rob. Just giving you heads up.
Yeah, you can haze me, ask me all kinds of oblique questions. I'll try to be as ready as I can be. But anyway, thank you. I come before you today to ask approval for a contract by Tier 1 to supply additional service to us in survey preparation with an interim quality director position. So this is professional services. So the scope of work for this particular individual will be to evaluate our current survey readiness plan to make sure that it's in accordance with best practices, and also to really be the point person for our document preparation process for survey. So we expect that Joint Commission will probably be here in early calendar year of 2021. They are behind, so we don't anticipate that they will be here ahead of schedule, but somewhere in the range of February, March, April, we expect that they will be with us. The document piece is even more important now than it was probably before, because there's a chance that we may actually get a virtual survey, which would likely be very document heavy. So we have identified a very large lift in terms of making sure that we are ready for survey from a document standpoint. So this will provide us with the additional support and background necessary to get us ready for Joint Commission survey. So the contract is a 90-day term, $99,000 with $9,000 for additional expenses for a total of $108,000.
Okay, any questions for Dr. Stevenson? And the exemption is based on the timeliness of it, correct?
Yes. Timeliness and also the I believe this qualifies as professional service.
Okay. Good. Any questions for Dr. Rob? I would entertain a motion.
Recommend approval.
Motion by Dr. Weber. Do I hear a second?
Second.
Second by Ms. DeBose. Thank you, Dorothy. Any further discussion? All in favor of the motion, please signify by saying aye.
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 Opposed? Looks like you didn't pass, Rob. Sorry.
Mr. Chairman,
right.
If I may, I want to make note about the high level of intelligence of Karen Duncan. She's a young lady from Ohio, and she properly positioned herself in front of the Texas flag when she presented. And that level of patriotism, I think, really helped pass a lot of what she did. So congratulations to Karen in her acceptance of becoming a Texan. We're very proud of her.
Well done. Well done. It probably was so subtle, most of us didn't even notice that. So, all right. So the motion passes. We'll give it to him this time.
Thank you.
Thank you, Rob. We'll move on to item L. Mr. Mendenhall.
Good morning, Mr. Chairman, Mr. Montgomery. I have 4 contracts in front of you this morning. We'll start with the first one, which is a contract between Sun Nuclear Corporation and Tarrant County Hospital District. This is a 2-part thing from an exemption to bid perspective, as well as for the contract itself. Sun Nuclear has provided for us the software and the hardware for 2 linear accelerators at our cancer center. This particular contract is the services contract, the support contract for the software, the QA software, as well as the dosimetry software that watches and monitors the radiation levels for the patients, as well as our service provider, care providers that are out there. So this is the service contract for that software, and I put it before you and the exemption to bid for this contract.
Thank you, David. Any questions for David? Hearing none, we'll entertain a motion.
Recommend approval, Steve.
Motion by Dr. Weber. Do I hear a second?
Zim, second.
Second by Mr. Zimmerman. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you all. Thank you, David. Next item, please.
The next item is an interlocal agreement between JPS and the Texas DIR. So the Texas DIR, the Department of Information Resources, is, for lack of a better phrase, they're a GPO that we are a member of for technology resources, and we do a lot of work with the Texas DIR. This particular interlocal agreement that we're entering into with them is for advanced security services and shared technology services program. So if you remember me speaking last week when we talked at the budget workshop, one of the things we're very in tune with for this next year, and I think even DT, you asked about managed security providers. We've been working on this contract for about 6 months with the DIR, so we could get some pricing from their organization on the managed security providers that are out there. So this is that way of getting that specific pricing, is to enter into this interlocal agreement with the Texas DIR.
So David, that you helped clarify that a bit for me. So DIR is not actually the provider of the security services, but they're a conduit by which we can get favorable pricing for security services.
Absolutely, Steve. That's exactly right. Just like we have Vizient that we use for a GPO for a lot of things. And we use Vizient, to be quite honest with you, for a lot of technology things as well. But for specific services like this, when we want to use Texas companies to be able to handle these things, usually we get better pricing from the Texas DIR, and that's why we're entering into this interlocal.
Okay, and DIR has their scoop in the water for some of this, right, in order to facilitate that transaction. But because it's just so counterintuitive to me when I saw the DIR, because they're not a vendor. They're
yeah. So no, that's a great question. So let me talk specifically about that for this. Usually with DIR, we get a pricing and then we can go directly to that vendor to enter into a contract. with this, DIR has entered into, I don't want to say a VAR relationship with these vendors, but they are kind of the acting title holder for many of these vendors when it comes to security. And the reason why they did that is when DIR entered into this particular game, if you will, or this particular industry of managed security providers, they were doing it for several school systems, and they were doing it including UNT and a lot of the ISDs that are out there. And so it was easier for them to enter into the paper holder as opposed to just providing a quote.
Okay, thank you for that. Any other questions for David?
I have a quick question, David. Since this is the initiative from the county, I guess, joint or whatever that call it, how come they don't meet the requirement for the hub or the WB and all that stuff?
So that's a great question. So we're not purchasing anything from them at this particular point in time. The interlocal agreement that we're doing, once we get to a point of purchase, then we will force that, or not force, but ask them to talk to us about the diversity plan and so on and so forth that they have. This is just so we can get pricing from them. And the arm of DIR to enter into this interlocal, they don't have vendors that are working it, they're doing it themselves.
Oh, I see. Okay. All right, thank you.
Any other questions for David? Okay, I'll entertain a motion on item M.
Move for approval, DT.
Motion by Mr. Nguyen.
Second.
Second by Reverend Emerson. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you. Item N.
So the third one is an agreement between Siemens Healthcare and JPS for services, and this is software services again, for our cardiology area. So when our cardiac cath lab, to be quite honest with you. And Siemens guarantees, you can see it right there, a 98% uptime with that software and with that hardware. So this is the Singo census system that we use for documentation with all the cardiac cath lab when they're doing their procedures in there. We did not have to go out to RFP on this because we were able to go out to GPO on Vizient to be able to get this pricing from Siemens. And so if you have any questions, I'll be happy to answer that.
Any questions for David? Hearing none, I'll entertain a motion.
Move approval.
Motion by Reverend Emerson, a second by Ms. DeBose. Is that correct?
Correct.
All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, David. And lastly, item O.
The final contract that I have in front of you right now is a purchase agreement with Prescriptive Data Solutions, Data Solutions. This did go out to RFP to replace actually a lot of storage that we have in Richardson Data Center. So if you remember from previous presentations, our Richardson Data Center serves as our primary data center for Epic. And so the Epic storage that we have there currently was purchased by a company called, or from a company called Hitachi Data Systems, HDS. HDS has not continued to be a strategic platform or organization for us. And in fact, they're really not even a company that's continuing to build out storage as a product line for their company. So we have went through an exhaustive, probably 12 to 18 month process of selecting other vendors. We did bake-offs from EMC, from NetApp, and other storage vendors. Even IBM came to the plate. We have chosen NetApp as our strategic storage solution for many reasons. And if you want to know those reasons, I'll be happy to answer those questions. But this is our second purchase of NetApp, and it'll be our strategic platform moving forward.
But David, is this different than the NetApp that was purchased in June of last month?
Yes. So part of what was purchased last month was for our JPS data center, and that was for a secondary backup of our data that we have here. This is actually going to be replacing the primary storage that Epic runs on moving forward. So we'll actually be able to have mirrored copies on both sides of it. We've been building up our net app over the last 18 months, just a little bit at a time. This is the first really big purchase we have done with NetApp.
Oh, I see. And I may have missed this one, but prescriptive data solution, is that more like a GPO type thing, or they more like a distributor?
No, they're just they're a distributor, but they're also a professional services organization to be able to do the implementation. They are part of the Texas Dir, and so I did say that wrong. This actual purchase is coming through the Texas Dir. So we did not go out to RFP for this one. But Prescriptive Data Solutions, they are actually a relatively new company, about 2 years old. They spun off from a company, if you remember, we previously used to do a lot of business with a company called Luminate. And Luminate went under, if you will, about 3 years ago, 2-3 years ago. And many of the principles, not, praise God, not the financial principles, but the technical principles of that organization built up Prescriptive Data Solutions. And we've been using them for smaller projects for the last 1.5 to 2 years. And now they are really an enterprise company doing big contracts. And this is one of the contracts for us.
Oh, I see. So this is both operating and capital budget.
Yeah, this is the biggest part of this is the capital side of this, right? So the 523 is the capital, the 19 is the annual support that would be moving forward for us. And that number, the first year obviously has 0 support. The 19.7 will be for year 2 and 3 moving forward when you do the math. So this is both for the capital and for the annual support for the next 3 years.
Thank you.
Any other questions for David on this item?
Can I make a motion for approval?
Yes, sir. We have a motion by Mr. Nguyen for approval. Do I hear a second?
Second.
Second by Mr. Bose. All in favor of the motion, please say aye.
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 Opposed? The motion passed. Thank you, David, very much.
Thank you, guys.
Counselor, I believe you're up next on item 6.
Yes, Mr. Chairman, there were 37 contracts in the month of June negotiated that were under 500,000. Those have been posted on your board website portal. And I have nothing. And I have nothing. I have nothing for executive session.
Okay, we have nothing executive session. I think that would mean that we are ready to adjourn. Let me ask. Do we need to take a 15-minute break before HR, or are we allowed to? I'll leave that up to the chairwoman of HR. So the Finance Committee is hereby adjourned. So thank you for that.
We will need to wait for HR to begin until the posted time.
And the difference is not only do we do training where we go and work with in our environments with our leaders and their teams, but we also are focused on online training. So we have created a compliance curriculum where now you actually go into go into a system and you do training at the beginning of the year on CBLs that helps us to know that everyone has the basic understandings of diversity and inclusion and what's expected of them as an employee and where to go if they need assistance. So you'll see those numbers a lot higher because now we have individuals attending those sessions as well. In addition to that, we have really focused on several different areas, and you'll see in the graph that's highlighted there that you're going to see actually the breakdown of what that training looks like and how we get to that 9,267 number. But basically, we deal with customized training. That was a special request where we're asked to come in and to assist and to equip our leaders. And then we've also had lots of training around serving with sensitivity and improving patient outcomes. If you remember in the planning stages, we came to the board and talked about our plan to do that. I'm happy to report that those sessions were very well received. We conducted serving with sensitivity on cultural competence, serving with sensitivity with mental health, also serving with sensitivity with the homeless population and gender identity. So there are many, many subject areas where we actually brought in subject matter experts to discuss real life patient cultural competency issues that were there. Okay.
Michelle, can you give us a few examples of the customized training or special requests? I may have missed that one. What are those?
Yeah, customized training, good question, are any situation where a leader feels there's a need. I'll give an example. We often get a leader that will call and say, this is what's happening in my department. Someone has perhaps said something that was perceived to be insensitive or concerned by someone else. And so that's caused some issues with the team. And we want to be able to communicate openly, sensitively, have a safe environment, and we need some help. We just need some help with that. We do not go in with a canned approach. We listen to the leaders. We understand what the need is. And depending on what they give us, we customize the education or the discussion or whatever intervention that needs to happen in order to make sure that they address those issues. And so those are things that come up just on a regular basis for us.
I know we start down this journey on diversity for a long time. And the inclusion was kind of making it into this. How mature is that side of it compared to the diversity side? So I know it's a multi-year type thing. It's a long journey, continue to evolve.
I agree, yes. Definitely a marathon and not a sprint. With diversity, obviously, I feel we're doing very well with understanding that there are differences in the workplace, and we value those differences. We value individual, not only demographic differences, but thought differences and approaches that people bring to accomplishing problems. We know that diversity is an asset and not a liability. And I think we're doing well with looking at diversity. Someone said that diversity is being getting an invitation to the party, but inclusion is being asked to dance. So your question, DT, about how inclusive we are and getting ideas of everyone and making sure people feel welcome and are comfortable is the second wave of where we're focusing. I think we're definitely moving in the right direction with our inclusion, and I think it's at the forefront now of our communication when we talk about the diversity aspects that we have to accomplish.
Do you think I might be ahead of myself if you may cover it down the road, but we have diversity, we have inclusion. At what point do you think we can move into cognitive
Move into what, DT?
Cognitive diversity type thing? Or is that going to be just separate between diversity and inclusion? Are we a candidate to move toward that goal?
Okay, I had a hard time hearing you also. I heard diversity and inclusion, and when can we move towards what?
Cognitive diversity.
Oh, cognitive diversity, right.
Okay.
And would you define cognitive diversity as you see it, DT?
It's more of looking at background, experience, and perspective that will cover everything that we can think of from a diversity, from gender, from sexual orientation, from all sort of things, right? Because you start looking at people from a background, experience, and perspective, then you put yourself in their shoes so that you can understand, so that we can lower the misunderstanding and all that stuff. Because if you understand people from where they come from, you can kind of know why they think that way. So you can find a way to resolve things a lot better too. But I'm not sure it can apply into our facility, but if it's not, it's fine. But
it definitely applies, and I would say that that is the direction we're moving into, and I see that moving in the direction with inclusion. As you start to move from just diversity to, say, inclusion, you understand that you include different thought processes, you include different perspectives, you include different approaches, and actually those are the very things that help move us towards achieving our goals, which we're here to achieve every day. So I do see that more of a part. I think we've started that process, but I see that growing, and I see that continuing as we start to look at diversity from a much broader perspective in many dimensions. So just to give you an idea, when we teach on diversity, we teach dimensions of diversity, and those are not just the core dimensions that people think about: age, race, gender, sexual orientation, religion. Those are not just the core. We talk about background and differences and geographic locations and work processes and work thoughts of how you work and work well with others and those types of things as well. So it is a part of that.
I have a concern totally with that. And my concern is that you can get that deep if you want. I understand that about diversion and inclusion. I'm all for that. But when you move out of that arena and you're looking at individuals' background and history, if you don't have the well-trained, proper evaluators of that, we're right back where we started. And so I just want to make sure we're careful of who those persons are that evaluate and look at that and do the review going into that process. And so I just want to express that.
Yeah. I think we have to have a strong foundation on the other two before we can even look at that perspective, without forgetting that that's where the goal and the foundation should be. If we just skip completely, I agree with you. We're back to where we're at.
Very good. And I think that the key foundation that we try to lay our anchor on is what we're here to achieve. And we look at transforming healthcare in the communities we serve. We start to draw from what do we need to accomplish that. And we know we need diversity. We know we need inclusion. We know we need cognitive diversity. We start to see how all of those fit. But the anchor, I agree, is to stay focused on the vision and mission and make sure when we're moving in those steps, as Reverend Emerson has said, that we have the right people to help us move along. So I agree with that. Okay, one of the examples that's on the screen there is gender identity. This is one of the sessions we did. I mentioned there were several, mental health, homeless awareness, but in this particular session, we did pre and post testing. Not only are we looking at evaluating training from a number standpoint, it gives us an indication if we are offering programs that people need and want. So we've had good success with attendance, but we also want to measure pre-post. Are we able to accomplish what we want to accomplish from a pre-post setting? So you see the pre numbers there, and then you'll see the post numbers. It's just an indicator that people understood the basic concepts of what you were trying to teach in that session. Next slide. All right. So as we look at training that we've offered, we now are in a different phase, and I'm excited about this phase. And as we started to look at what was needed to move forward in light of some of the current issues that are going on in our nation, issues that start to impact us not only outside, but when we come to work, we really recognize that there was a need to continue to protect our safe place for employees. And when I say safe place, yes, we were concerned about physical safety and making sure everybody's comfortable, but we're also concerned about safety in terms of a safe place to work where I can go to work and feel like I can communicate, I can share, I can have a different thought than someone, I can have a different background, and I can relate to people in a way that's safe. So in light of the George Floyd situation that happened in our nation, where individuals literally saw this individual lose his life, we had lots of pain and emotion around that within, as we all know, it impacted us in different ways. Employees were starting to talk about these issues as well and wanting to express themselves, coming from different backgrounds and having to focus on how they were going through and understanding and reacting to this racial injustice. So we conducted, actually through the leadership from a high level leadership from the organization, Mr. Early and Dr. Duncan helped us to really focus on what we needed to address these issues from an organizational standpoint. So not just from a diversity and inclusion office standpoint, but from an organizational standpoint, what is needed to support our employees. And with that, a decision was made to bring in external resources to conduct a pulse survey. And that pulse survey basically just gave us indications of how people were feeling about what had happened in our nation, what issues had it brought up for them, and then with that, for our leadership to be able to participate in small group guided discussions. These
Michelle,
discussions were...
May I
Yes.
interrupt you for a second? What exactly is a pulse survey?
A pulse survey is a survey that checks the pulse of where individuals are. We had some groups reaching out, some groups calling saying there's tension in my group because of what's happening on the news every day and what I'm seeing every day. There's some tension where there's been disagreements about what should be happening and should not be happening. The pulse survey allows you to get a sense of how big are these issues or how are they impacting us. For example, one of the questions that we focus on in the pulse survey is what emotions did this bring up for you? How did this impact you? So it allowed us to get a sense, are people feeling pain? Are they feeling sad? Are they feeling depressed? And so it allowed us to gather and know exactly how to lead some of those discussions that were coming up. So we've had guided discussions, and I'm happy to report immediately when this was announced, I received feedback from the Office of Diversity and Inclusion that we are thankful to work for an organization that is willing to understand not only that these things are happening, but to take the time to address them and to allow us to have a place where we can communicate and work through very difficult conversations that need to happen in the workplace, and to know what things shouldn't happen in the workplace in terms of the way we express ourselves and what might be offensive. And so very, very helpful sessions. Our executive team was the first team to go through, and then our leaders have gone through the process with 30 people per session and had discussions. And this is the first of what we think are very important things to happen to come to help us continue to be comfortable and giving our insights on very diverse, sensitive issues.
Michelle, I just want to add one thing, if I could, and this is to Mr. Nguyen's question or comment around cognitive diversity. I think having these guided discussions is a really direct way to allow people to share how they think about things, and it really shows up on these guided discussions that people do think differently and people process differently. And it's a good example of cognitive diversity in action, so to speak.
Thank you, Alex. Yes. Okay, next slide. So our commitment to, we'll need to, right there. Our commitment to supplier diversity. We've talked a lot so far about diversity as it relates to what we're doing in the workplace and creating that environment and making sure that we create a safe space for our employees and that we're valuing and respecting opinions and we're able to take care of our very diverse patient population and that foundation of why we are here. In addition to that, as we look at our commitment to supplier diversity, we really still believe that attracting a diverse supplier base that is reflective of our community and serving our business imperatives contributes to many things. And just a couple of those we mentioned on the slide. It contributes to lowering our operational costs because we have more competition and encouraging innovation. We just talked about the value of diversity and the way people think, allowing that innovation and creativity, we believe also helps us support the overall health and well-being of Tarrant County. And so when we know that financial stability is important and it impacts our health, supplier diversity becomes even more important to make sure that we are contributing to the health of our community. So our supplier diversity classifications are there. I know that you are familiar with them. I'll just mention that we still have the historically underutilized business, the HUB classification. We also honor small, minority, and women-owned business enterprise classifications. Individuals with disabilities and service-disabled veteran-owned business are also a part of the historically underutilized businesses. And traditionally, what we've done with those businesses is we've used that in alignment with the state of Texas HUB classifications as well as the North Central Texas Regional classification. Recently in the Governance Committee, it came up that we need to look at our policy, LD 6000 and LD 6001, and there's some updating that needs to be done. And I know that's been part of the discussion that has been on the table, and I know that there's more to come. Just want to mention a couple things in that updating that were going to be very important to look at is the strategic objectives in terms of what our objectives are from our goal percentage. We have had 25% for several years now as an overall goal. I know the board has asked us to look at, do we need to drill down and have a certain percentage for construction versus professional services or other areas? And so that's some of the discussion I think that still needs to happen in reference to the updating of the policy. In addition to that, LGBT small businesses and their certifications are not currently a part of the policy and are not listed in the policy. And so as we look at businesses and small business certifications, we'll also need to look at what needs to happen as it relates to our LGBT businesses and making sure that we're counting certifications and counting all of our businesses towards that participation goal, and that we are developing relationships with everyone in the business community. So that is something I believe that needs to happen.
Michelle, what is our current hub utilization percentage overall?
I could not have paid.
We have a goal to spend 25%. Are we?
I could not have paid for that question. Next slide. It's on the next slide.
Is it? Oh,
yeah. So let's go to the next.
Read his book.
It's on the next slide. Can we go to the next slide? Okay, great. Let's look at participation and spend, and we have the historical data there for you from 2016. As you can see, we were at 6.8, 2017, moved up to 7.9, 2018, we were at 10.32, and then 2019, last time we were here, we reported on 17. Because of meetings before the last HR committee, we only did education, so we never reported at all on 18. So this is the first time the board knows that 2018 was 10.32. 2019 is pending, and the reason that's pending is because we are still verifying our tier 2 spend. It's still very much a manual process from that standpoint, and so there's still some extra checking that needs to happen. But we do anticipate 2019 being close to 2018 in the actual numbers. So that's where we are.
Do you know how that compares to other systems?
I know that the goal of 25% is comparable to what we see with Tarrant County and the city of Fort Worth. Some of them may be 20 or 25, but it is comparable to those areas. We do know that many of them have drilled down where they are specifically looking at the different areas and identifying where that spend is coming from. And so as we look at from a construction, for example, versus professional services versus other areas. And so we do believe it's necessary as we evaluate that policy to look at the drill down and what really makes this based on our historical spend in setting those goals.
But we don't know how, say, our 2018 10.32% compares to Parkland or any of our benchmark hospitals percentages.
Yeah, I do not have that data.
Okay. I'd be curious to see what that number looks like if we're able to obtain that information.
Okay, and we can get that data. We definitely can. I think it'll be important for the meetings and the communication around where we need to set the parameters around spend and measuring.
I'm just really curious. I mean, we've got a 25% goal. If we choose to say, okay, we want that to be a 30% goal, I want to make sure it's a goal that we're, working in the direction of actually being able to obtain. And I'm curious with our other hospitals or our other benchmark hospitals, I know that they're doing the same thing. And I'd just be curious to see if we're right in line where they are, or we're way over where they are, or they have some secret magic that we don't have.
Okay. And we will get that data for you.
Thank you.
Okay, well, we will put that down for our next meeting to have that information. And I think we do need it before we start as we revise that policy. Okay?
I agree. Madam Chair, may I ask a question? This is Steve.
Yeah, go ahead.
Michelle, this is Steve. I have a question about this, kind of tagging on to what Roger was pursuing. There's a trend line that's improving here, which is good, but I have to tell you, I mean, those numbers are pretty discouraging. If we have a 25% goal and we're not even halfway there, from your perspective, what are the barriers that are keeping us from getting closer to those goals, and what can we as a board, what tools do you need from us for us to do better? Because I have to tell you, those are really discouraging numbers to me.
Well, I'll jump in there and say your comments are really encouraging to me. And so if your question is what can the board do, they can do exactly what you just did, which is to keep the pressure on us to perform better. And these goals, though, are better than some. What I focus mostly on in this role is what are we doing, and not what others are doing. What is the goal from our board of managers? The goal from our board of managers is 25%. And so that's the goal we're going to try and achieve. And to that end, the only other piece that I think is important here is that spend is incredibly important for a supplier diversity program. I recognize every day when I walk in from the parking lot and I look at the patients in our waiting rooms, I recognize that they are a rainbow of colors and different races and ethnicities. And to that point, those people are essentially paying the bills. And we want to make sure that the businesses in their community and business owners that look like our patients are fairly represented in the spend. But there's another component that we should look at, and that is the impact that we can have beyond spend. And that impact is really about drilling down into these communities to find the businesses who are owned by diverse individuals and seeing where are we spending money with them today and how can we increase that spend? Because that impact is direct and it's felt right in our patient community. So that local spend from the zip code we serve is an area of focus, and I'm sure that Michelle's going to cover that in the next couple of slides. But thank you for that question. Thank you for that pressure, and I want you to keep the pressure on us.
Let me get Alex, with what you're saying, and I certainly support it, and just what like Roger said, if there's someone else that's doing better, what's their magic sauce that we can steal the formula? And drilling down, I think, is super important, and finding ways to provide mentorships. Someone might argue, and I can understand the argument, that we're a healthcare organization. We're not about building diversity or capacity in our community. But I would say the exact opposite. We're spending millions and millions of taxpayer dollars, local taxpayer dollars, and larger dollars, and it makes a lot of sense for us to build that capacity in our local community. We should spend it as locally as we possibly can and help build capacity. Mentorship programs. I would encourage you to look at other, how the city of Fort Worth's doing it, how Tarrant County's doing it, how Parkland or Bear County, any of the other entities, how and they may be having the same experience, right? They may be at 10.5% or so as well. I just got to think we can do better. So thank you for that. And I'm, as a one board member, I'm here to help. Whatever I can do to help, please let me know.
Steve? I appreciate that.
Hey, Alex and Michelle, I have a question too. This is Trent. And I'm kind of with Steve in terms of a little bit of frustration. I look back when Reverend Emerson was working on infant mortality and all the work that was done, and some of the stuff that Ralph learned and that he reported back to us that I kind of took to heart that seemed to me to be very, very applicable here is that sometimes we try to measure an end without measuring a means. And if we don't measure the means, then we never get the end that we're looking for. I don't see that we have the metrics that make this dial move, at least at the board level. I would like to see metrics that say what activities have we pursued that have taken us further into these communities to identify who these businesses are, what they have available. If we're just measuring how we're doing and we're not looking at what we're doing to get there, this is not moving quick enough. And I don't know if it's an issue of supply, that we just simply don't have the number of minority vendors. I don't know if it's an issue of them not qualifying. I would just like to see a little bit more detail in terms of the metrics that go into determining this number, because this is a pass or fail number, and right now we're failing. I'd like to get a little deeper into it and understand what we're doing to move the dial to get to this end.
I couldn't agree with you more. And the next slide will show you.
Before you go to the next slide, let me give you some. I don't have the latest number for Parkland, but I have a 7-year-old data. Mm-hmm. In 2017, the MWBE spent from Parkland was $30 million. Mm-hmm. So that was 7 years ago. So I think I'm agree with you, Trent. I think we need to look at, because there's not a lot of teeth in here, maybe the coordination with purchasing, but also we need to look at, if you want to really entice and help out the minority group, we have to allow them and understand, because sometimes their pricing don't have volume discount. They can't have access to, other companies may hire very competent people with stock options to lure them away and big bonuses, and small minority don't have that. So we may have to consider having a high but reasonable pricing to help that segment, and then we can monitor to see how successful they are in adding more and more people, so that they graduate to, at some point we can consider this is the threshold. Depends on, sometimes the bigger revenue doesn't mean bigger profit for them. But when we look at that to say, when do they graduate from this program so that we can use them as mentors for other small businesses and all that stuff, I think that's where we need to start cultivating that kind of culture. Otherwise, we can raise all the things that we want, but if purchasing is on the other side and looking at purely pricing, they're not going to even have a chance at the table.
Yeah, those are really good points. Absolutely agree with you.
Really good points. Okay, and I would like to move to the next slide because I'm excited. One of the things that Alex has brought to the team is the real challenge in this area to look at how well we are drilling down. So there's some new approaches I would like to just share with you today. So let's go ahead and move to the next slide. So as we look at supplier diversity in the core function, we're still looking at obviously impacting operating expenses and lowering those based on competition and then innovation, and we mentioned that earlier, and then also the effect on the economy and the business market in general. So we really see it as diversity is a core value. It's really no longer a program, and we're really trying to push out that thinking of it just being a program or even a department for that sake. It's really part of our core function of the procurement process. So I agree with what you said, DT, that we need to look at what we do with purchasing and in that procurement process and integrating diversity. But next slide is something that we want to share with you just as a snapshot. And these, you're going to see a couple of these examples. They're just that, examples. We wanted to let you know that we are as concerned as you are about those numbers and started to look at how can we do better. So one of the things that we pulled is demographic data, and we connected that data to our clinics, our patient population, and our clinics. So we started to look at where are our patients and what do we know about them? What's the makeup of the patient population in certain areas? So this is just an example. We could have used examples in many other clinics as well. And we do have access to the additional information. But for this one, we looked at the zip codes for the areas where our patients come from in stop 6. And then we drilled down further to look at what percent of population. Then we looked at, to answer the question someone just asked, is there a capacity problem? Do we have enough businesses in the area? So here we started to answer those questions about capacity as we looked at vendors by zip code, and then current JPS vendor zip codes. So it lets us know where we have vendors and then where we have some opportunities. We're also doing that, if you go ahead to the next slide, we actually started to look at where are some vendors in that area. And this gives us an example of businesses and zip codes that are in that area and how much we're spending in that area. Why do we need to know this? Well, it helps us as we look at what types of businesses and who do we have enough of certain areas. So it also helps us with setting goals and objectives. So we are already focused in this area. This is a snapshot, and literally we just started to look. If you look at the next slide, you'll see we did the same thing for another area, Viola Pitts. Same methodology, just to look at the zip code, look at what percentage of total and the breakdown, and then look at our patient population as well.
I'm going to jump in real quick, Michelle, and just say, pardon me, and that is, we're doing the same thing for our Latinx communities. We're doing the same thing for our Asian communities. We're getting very granular about this. And Mr. Petty, your comments, though we didn't address them head on directly, they were heard. Mr. Nguyen, your comments were heard around pricing. Absolutely. And I just want to comment to those two board members to say that a piece of this is intentionality, right? And I've been here about 6 or 7 weeks, and I can tell you at no fewer times, no fewer than 4 or 5 times have I heard from Mr. Early and Dr. Duncan about the need to ensure that we are moving the needle on supplier diversity. And so not only do we have the pressure coming from the board now, which we appreciate, we have the consistent pressure coming from Mr. Early and Dr. Duncan. So we understand clearly we need to move the needle. This information that we're presenting to you today is baseline. Mm-hmm. It is baseline because it hasn't been looked at before in this manner. And so in the future, we will present you how we're moving the needle from where we are today. So I just wanted to add that piece. Thank you.
I have a question. If we go back to step 6.
Mm-hmm. Can we go back one slide, please, Derek? Thank you.
On that one, so these are the vendors that provide the services there. So in no particular they are minority or not, right? It's just basic vendor that
they are diverse vendors.
They are diverse vendors. When I look at office authority, they don't look and sound diverse. So I don't know if they qualify.
So again, then you have to, Mr. Nguyen, you have to look at how we define diverse vendors, right? They are historically underutilized businesses, hub businesses. And so depending on your definition of diversity for this conversation today, the definition of hub does not necessarily mean a person of color, right? Or a certain ethnicity. It simply means that it's an underutilized business. It can be a disabled veteran-owned business that's underutilized. That could be owned by a majority Caucasian person.
When I look at the website, the true owner seems to be Caucasian, right? Non-veterans, and also highly educated from private institution. And then when I look at their zip code, they don't belong into 76104. They belong to 76110 for that office. So you might want to take a look at to see are they.
Michelle, you might want to take a look at that. Okay. Thank you, Mr. Nguyen.
Oh, thank you.
You're not on. You're. Yeah. There you go.
Yeah, I'm on. We will definitely take a look at that. Also, the other category, I just want to remind you of small business. The small business designation has to do with the economic amount that business drives. And so that could be another one of those reasons. But we definitely will take a look at that and make sure.
Yeah, they tell to multiple states, so that's why I'm a little bit confused. But the zip code is not in the same area even.
Okay. Okay, let's go to the next slide. I think we covered Viola Pitts and then the businesses. We can go ahead and advance to the next slide. Same methodology, looking at businesses in that area as well. Next slide. Well, we really want to communicate, and we know that that's a snapshot. I think that the clear communication is that in order to move the dial, we believe we needed more targeted vendor outreach, a vendor approach. And we have done things in a general form. If you look at the history of where we've come, and by the way, that is good news. We started with not having outreach at all. We moved that into quarterly vendor outreach sessions where we had up to 100 vendors every quarter coming to hear how to do business with JPS, not just from a diversity and inclusion standpoint, but from a procurement standpoint, construction standpoint, IT. So we coordinated and partnered with individuals to accomplish that. So we did general. We've done 101 sessions in person where we have representatives from the Office of Diversity, contract owners, and vendors bringing their capability statements so we can better match. And so we've built a strong foundation there. But now in order to move the dial further, we really believe the targeted approach is going to be one of those answers. And we continue to look at other ways to improve. So that's where we're focused. And you just saw the data, so we don't have to go through that. But basically analyzing and then identifying where we need to focus our outreach, and then establishing the overall plan that has to do with the policy and procedures and targets, which are perfectly timed because that's what we're working on now. Okay, next slide. Partnering for change in our supplier diversity journey. It is a partnership, and so we really recognize that we need to reflect the ever-changing demographics that are around us. And so we're constantly looking for ways to do that. That's why we looked at the patient data. That's why we looked at who is there also. So really important to continue to create change, build a better future for us all. Next slide. In closing, what I'd like to leave you with as we look at the diversity report today, the report that we really want you to leave with is an understanding that we are continually to be committed to diversity and inclusion, and the broader sense, the broader approach of diversity and inclusion, which entails not only a safe workplace, a respectful workplace, patient population, and looking at disparities, but also our supplier diversity initiatives. And so we will continue to move those efforts, and we are ecstatic to have Alex with us and helping to lead us in areas where he has vast experience. So we really feel fortunate, and we are so thankful for the board for your support, as well as Mr. Early and Dr. Duncan. We thank you for all the efforts that you have put forth in this area. And so that is our report for the day. Alex, do you have any other closing words?
Michelle?
Yes.
Michelle, before you close, I have just a couple of comments. One is I do appreciate the comments from many of the board members today in reference to the diversity concern and the policy as it sits. It brought back some memories. Steve was my chair when I began to raise the question about diversity in JPS. One of the things I've had a fear, and I say this to the entire board, and not maybe such a fear, but a concern, is that so often when I've brought up about diversity, individuals I feel think I'm talking about Black presence, and I am not referring to Black presence as I am fair presence, and that we address the diversity issue as it comes to diversity, minority spend to include employment. When I was the chair of the board for the infant mortality, I took a trip to Detroit to a conference, and where I myself learned what institutional racism is. I had my own personal education, and one of the things that was emphasized with institutional racism is not so much the individuals who work in the organization, but it's the rules and the policies that have been established and been sitting there for years, and no one has ever addressed them. And that's one of the reasons I raised about the 25% that we have now. I think there are some issues we need to address as a board, the diversity office to sit down and address an example, we just accept, well, they're an exempt firm, we pass on. And I think that if they are a firm doing business at JPS, I don't care who they are, they need to address our policy. And I think our policy now has gotten somewhat antiquated. I think we need to take a serious look at that. One of the things that we looked at, and I was glad to hear Trent, because when we, in the infant mortality issue, we were studying infant mortality and as it relates to institutional racism. And one of the things that we did was, and I think we maybe need to do that in some kind of way, working with the Black Chamber and Hispanic Chamber, be that as may, but the community assets that sit out there, because there are probably a lot of individuals or underutilized businesses that could qualify, but no one's touched them. And so I want to say that what you presented today was great, but I think there's a step, and it was good to hear Robert say this, and he said it to me several times, but it was good to hear him say today, well, as the CEO, I need to talk to the head of BKD, but also, and what I heard him say was, I am committed to make sure the heads of JPS are committed to addressing the issue of diversity and inclusion as it sits here at our hospital. Because when we talk about supplier and diversity, if the department heads in JPS are not committed, I don't care how much training they get, if they're not committed, we'll be sitting still doing the same old practicing institutional racism. The George Floyd situation, I understand that. I didn't agree with that, but institutional racism and the lack of diversity, it was going on way before George Floyd was killed. We just have not opened our eyes to admit that it was there. And it's good to hear a board say that we are committed to doing that. So that's my spiel.
Well said. Thank you, Reverend Emerson. Alex, did you have anything else? Doug?
Dorothy, you're on mute.
Did we lose her?
We can't hear you, Dorothy.
Can't hear.
Does your volume need to be turned up, Dorothy?
We move to John.
DT.
T, I'm telling on you.
You know, motion? No, I'm kidding.
There goes my cookies.
Okay. Does she have AirPods in?
No way to text her on this, huh? I can text her, me. You doing, Dr. Don? Okay.
I can call her.
I think Dr. Duncan's texting her right now.
Yep, she's gone.
She's now back in. I just talked to her. Her mute button wouldn't unmute, so she's calling in back. Yeah.
Dorothy talking?
It's Dorothy calling me. This is Dr. Duncan. She says she's tried twice to get back in.
She's online.
Okay. Well, thank everybody. Michelle, I love your presentation. And I wanted to make one comment to everybody. I think as a board, what we said today at the Finance Committee is putting some teeth into getting our spend and our programs up. We as a board, when we get those forms, we just say, okay, we just keep on approving what comes through. And I think we need to play a bigger role in that. Okay? I'm ready for Alex. If you are ready to go ahead. Maybe they'll get me back in.
Hi, thank you, Mr. Bowles. Great. So this is our last item for today, and it's a goal that we have, and that's why we're reporting out on it, and that is our new hire turnover. And new hire is defined as those who join the organization and are with us for less than 1 year, one calendar year. I'm sorry, one fiscal year. And when calculating this metric, it is the number of employee terminations with less than 1 year of employment by the monthly average or number of employees with less than 1 year of employment. We had been improving in this area over the last several months, since October of last year, and had seen some significant improvement somewhere in the mid to high 20s. We then got bumped back up to around 33% as of June, and I think all indications are that COVID had a mighty hand in that increase, as is a case across the country. That 1 year turnover for those entering, many of those are people who are entering healthcare for the first time. Some have been involved in healthcare for a number of years in their career, have decided to leave healthcare because of COVID. And so we're not surprised at all by that increase, that tick up, and it will probably remain at this level or get a little higher, as depending on how long COVID hangs around. But we expect that this metric may be somewhat of a poor metric for us to track over the next several months, but we will still keep an eye on it and still report out. But just wanted to just touch base about it very quickly to say that's one impact of COVID, not surprising whatsoever, but wanted to report out on it.
Madam Chair, may I ask a question? I'll take that as a yes. Alex, thank you for that. And I guess the caveat is that these are the first year employees, right? I mean, so your turnover rate anticipated to be maybe higher than a longer term employee. You kind of figure out that first year whether it's the right fit.
Yeah.
Perhaps because that's such a high number to me. Perhaps in future meetings we could see, maybe it broken out among longer term employees, just to see how we compare to national. I went and looked after I saw that 33%. I went to Bureau of Labor Statistics just to get a feel for what the national averages are, and they don't break it out with the first year, but they break it out overall, and they're half that.
Right.
And so maybe in the future we could also see numbers on just sort of what longer term employees, what our turnover rate is, because turnover, as you well know, is such an expensive proposition for any organization.
Yeah, absolutely. Yeah.
Well, thank you.
You're welcome. Thank you.
One other comment with that, Steve. I think I don't know if Michelle is still on or not, but they did. Michelle and Pia did give us that kind of information at a couple of board meetings some time ago about longer term employees and what that breakout was. So we have seen some data in reference to that, and we might want to look at that. I think it's there.
Ralph? Ralph,
yeah.
Can you hear me?
Yeah.
We were getting it by divisions as well.
Right. You're right, Chuck.
And I thought I'm with you. We were getting it by a pretty good breakdown. I don't remember if it was less than, if we looked at it by years, but you're right, data's there.
Right.
Well, Mr. Bowles, I'm not sure if she can hear me or not. Do we know if she's? That concludes our report. Thank you very much, Dr. Weber and the board.
Alex, I know that Amanda is having some challenges, as well as Dorothy is having some challenges. I don't know if it's in the air or not, but I know that people have been having some difficulties. So if you want to, before we end the meeting, if you want to check the chat room, if there's any questions that are the chat room, that might be helpful. Make sure that Amanda has the opportunity, because I think we can use the chat room, but maybe we can't hear or see her. And Dorothy's challenged right now. Luckily, we did not have to go into any further business. But if you take a look at those, Alex, that would be helpful just to make sure before we adjourn the meeting.
I just talked to, if we don't have
right now, Mr. Earl.
Okay. DT, you had a question or a comment?
Oh, no, I just talked to Dorothy. She have a hard time getting back in, but she said if we don't have any outstanding question or follow-up, then you're free to close out the meeting.
Okay.
Back to the CEO.
Okay. Alex or David, do you all see anything in the chat room or anything in
no,
anything?
Nothing at all.
Okay. All right. Well, if it's all right with you all, since Dorothy is not able to hook back up, and I was having problems in the middle of the meeting, but we'll go ahead without further we'll go ahead and adjourn the meeting. I thank you all for participating, and thank you for working through your y'all gave something to this, and very good questions from y'all. We appreciate them, and we will I'm guessing most of you all tomorrow. Thank you all.
Thank you, everybody.
All right, see ya.
Adios.
Thanks, Rob.